In emergency medicine, there are these moments, these razor's edge moments where everything just hangs in the balance. A patient's body is on the verge of shutting down, and clinicians have to reach for a drug that's, well, it's both a lifesaver and a total high-wire act. Today, we're diving into that very drug, norepinephrine. It's the powerful intervention they turn to in the absolute most critical moments. So, let's get into it.
So picture this. A patient is in shock. Their blood pressure has absolutely cratered. Now, this isn't just some number on a screen. It means that blood, the stuff carrying life-sustaining oxygen, isn't getting to the most important places. We're talking the brain, the kidneys, the heart itself. The whole system is right on the brink of a catastrophic failure.
Okay, so in a situation like that, the first line of defense is usually to pump the patient full of fluids, right? You try to increase the volume in their circulatory system. But here's the thing. Sometimes that just isn't enough. You can fill the tank all you want, but if the system has lost its ability to actually create pressure, the crisis keeps going. This is what we call life-threatening shock, and it needs a much, much more powerful response. And that's exactly where our subject for today comes in. When fluids just aren't cutting it, clinicians call in the heavy hitter, norepinephrine. It's basically a synthetic version of a chemical our own bodies produce, and its job is simple but honestly profound. Bring the pressure back, and do it fast. You can think of it as the body's ultimate squeeze chemical.
So what is norepinephrine exactly? Medically, it's known as an alpha and beta-1 agonist. But what does that mean in plain English? Well, the alpha part is all about that squeeze, the vasoconstriction. It literally clamps down on blood vessels. Imagine squeezing a garden hose. What happens? The pressure of the water inside shoots up, right? That is exactly what norepinephrine does to the circulatory system. And then you've got the beta-1 part. That gives the heart muscle itself an extra kick, boosting its contractility and helping it pump way more effectively. And the reason it's such an incredible emergency drug is its speed. I mean, we're talking an onset of action of just 1 to 3 minutes. The effect is almost immediate. But, and this is a big but, its duration is only about 5 to 10 minutes. So this isn't a one-and-done kind of shot. To keep that patient stable, norepinephrine has to be given as a continuous, precisely controlled IV infusion. It is a moment-to-moment balancing act that the clinical team has to manage perfectly.
Now, with a drug this powerful, you can't just throw it at any patient with low blood pressure. The decision to start norepinephrine is a huge one, and it's governed by some really strict rules of engagement. So let's take a look at the specific scenarios where this is absolutely the right call. These are really the primary battlegrounds. You've got severe cardiogenic shock. That's when the heart itself is just failing as a pump. Then there's neurogenic shock, where the nervous system completely loses its grip on the blood vessels, causing them to dangerously widen. And of course, it's the go-to for pretty much any kind of shock that doesn't get better after giving fluids. Basically, when the body has lost its own ability to maintain pressure, norepinephrine steps in to do the job artificially. But here's the flip side, and it's just as important. Knowing when to act is critical, but so is knowing when to hold back. Using this drug in the wrong situation can be ineffective at best, and at worst, downright dangerous. The risks are very real, and understanding the contraindications is absolutely essential for keeping patients safe. All right, here's maybe the most important rule of all. You cannot squeeze an empty system. It's that simple. If a patient's blood pressure is in the tank because they've lost a ton of fluid, say from major bleeding, you have to replace that fluid first. Using a vasoconstrictor on an empty vascular system, that's like flooring the gas pedal in a car that has zero oil in it. All you're going to do is cause more damage. You've got to fill the tank first. Other major no-goes include known hypersensitivity or certain types of blood clots. And this is the tightrope I was talking about. While you're trying to bring that blood pressure up, you can easily overshoot the target and cause dangerous hypertension. And while you're stimulating the heart, you can push it way too hard, leading to chest pain or, even more seriously, an irregular heartbeat, what we call a dysrhythmia. This is the potential collateral damage clinicians have to watch for every single second. A patient hardly ever exists in a vacuum. They're almost always on other medications, and those other drugs can create a really complex chemical dance. For instance, if a patient is on certain antidepressants like MAOIs, the effect of norepinephrine can be dangerously supercharged, which means you have to be extremely cautious. On the other hand, if they're on beta blockers, the heart's response might be blunted. It's a complex puzzle the medical team has to solve in real time. Okay, so we've covered the what, the when, and the why. Now let's get into the how.
The administration of norepinephrine is like a playbook where every single step is designed to maximize effectiveness and minimize risk. And in this playbook, precision is everything.
First off, it has to be diluted correctly. Second, and this is so important, it has to be infused through a large, stable vein, ideally a central line, using an infusion pump for absolute control. Why? Because norepinephrine is a powerful vesicant. That means it can cause serious damage to tissue if it leaks out of the vein. If that happens, it can cut off blood flow and cause severe tissue death, or necrosis. And finally, the dose is never static. It's constantly being titrated, adjusted up or down, minute by minute, to meet that specific patient's needs.
And this number right here is the goal. The entire effort, all that work, is aimed at hitting and maintaining a mean arterial pressure, or MAP, of greater than 65. Now that's not some arbitrary number. It's widely considered the bare minimum pressure you need to make sure blood is adequately getting to and perfusing the brain, the kidneys, and all the other vital organs. Anything below that line is the danger zone. Now, let's talk about a very specific, incredibly high-stakes scenario. What happens if the patient in cardiac arrest is pregnant? The guidelines here are unequivocal. When you're trying to save a life, you treat the mother aggressively. Any worries about potential effects on the fetus do not stop the use of life-saving drugs like norepinephrine. The #1 priority is maternal resuscitation, period. So, as we start to wrap this up, this is really the essential nature of norepinephrine. It's a molecule of just immense power. In the right hands, at exactly the right time, it pulls patients back from the very brink of death. But that same power means it is constantly walking this incredibly fine line between restoring the body's balance and causing unintended harm. And that really brings us to our final thought. Norepinephrine is a tool, a powerful one, but its effectiveness depends entirely on the skill of the professionals using it. So this daily high-wire act, the one being performed in ICUs and emergency rooms all over the world, is just a remarkable testament to the training, the vigilance, and the expertise it takes to manage the most fragile moments of human life.